Hi, my name is Puneeth Iyengar, and I'm an attending and director of the Metastatic Service in the Department of Radiation Oncology at Memorial Sloan Kettering Cancer Center. Today, I'm going to talk to you about an important topic towards all my patients, and I think a topic that would be of extreme interest to patients, to caregivers, to family members, and so forth. And it's continuing to refine our understanding of when to use local therapy. And when I say local therapy from here on out, that alludes to radiation and or surgery in the management of advanced non-small cell lung cancer. And I'm very glad and happy to be working with Grace on putting this talk together. These are my disclosures, none of which are relevant to this presentation. And so just to give you a broad overview of what I will be talking about, I'll be talking about NRG-LU002, which is a very large study that I was the principal investigator on, to give us some insight on what we're finding when we use radiation in the management of metastatic patients, how to better understand patient selection and prediction and reduction of toxicity when we do use radiation for metastatic patients in a curative intent, and thinking about, and I did say curative, there's some subsets of advanced non-small cell lung cancer patients who live a very long time, and we want to improve the durability of our treatments so that all patients can live a very long time. And then ultimately, in the second half of the talk, anticipate future approaches we may use to better understand the ideal timing and sequencing of radiation in management of advanced non-small cell lung cancer patients. So if we just take a step back, we all know now that biology really affects non-small cell lung cancer outcomes. And what I mean biology, I mean whether you have an EGFR mutated tumor or not, whether, for instance, you have an ALK mutated tumor or not, whether your tumor expresses mutant or wild type KRAS, whether it's a squamous versus a non-squamous histology, the extent of PD-L1 expression. And now this talk highlights the fact that patients that have what we consider having oligometastatic disease, do those patients do better than the patients with diffuse metastatic disease? And do we understand really metastatic trajectories to optimize the sequencing of local and systemic therapies? And so these are all the things that we'll get into in subsequent slides. I will say that without a doubt, and many of my colleagues and friends are co-authors on this publication, this and many, many other parallel publications have now optimized as much as possible the role of systemic therapy in the management of metastatic disease. We are seeing the kinds of improvements we are in overall survival and progression-free survival because systemic therapies have gotten better. Systemic therapies can be better cytotoxic chemotherapies, certainly the era of immunotherapies, newer classes of immunotherapies, including antibody drug conjugates. It could include targeted therapy for EGFR mutated tumors, ALK mutated tumors, etc. So all of these treatments have improved survival outcomes. But what you can see on the curves on the right, with my red arrow pointing up, is there's still a lot more we can do to optimize the benefits that these systemic therapies can offer patients with respect to overall survival. So why did we even consider using local treatment for metastatic disease? Historically, local treatment for metastatic disease has been used for palliation. We would often radiate a tumor that's causing bleeding. We would radiate a tumor that's in a bone that's associated with pain in the metastatic setting. We would use radiation to reduce the size of a tumor in the lungs to avoid obstructive symptoms such as pneumonias and recurrent pneumonias. We would use radiation perhaps to reduce the size of a tumor to help patients breathe. But we were never thinking about use of local therapy in the form of radiation and or surgery to make patients live longer. But that all changed about 20 or 30 years ago. Then there were several reasons why our mindset changed about metastatic patients. One was that as systemic therapies got better, patients were living longer, which means that there could be an additional role of local therapy beyond just for palliation. Number two, the idea from the previous slides that systemic therapies are still not perfect and could use some help. Number three, improvements in diagnostic tools that allowed us to collect and identify disease at an earlier stage in the metastatic process. And four, this general idea of oligometastatic disease, which to us suggests that there's a window where some cancers learn only how to spread to a very few number of sites. They don't spread to other sites. And therefore, the question is, could we use radiation in those early sites that they spread to try to reduce the likelihood that they spread to new sites and to delay when they spread to new sites? And so this phenomenon is not surprising if we looked at our surgical colleagues and their findings over the last few decades. Surgeries have often been used to remove limited metastatic areas of disease, whether it's an isolated brain met, an isolated liver met from colorectal cancer, an isolated pulmonary met from colorectal cancer, or sarcoma, for instance, an isolated adrenal met from non-small cell lung cancer, and even isolated brain mets. So our surgeons have been more aggressive in trying to remove these areas of disease to prolong survival and patient outcomes. And so radiation oncologists finally started saying, hey, we could do this with radiation as well. But the reason that radiation oncologists thought this was very possible was for several reasons. Number one, as I've talked about, systemic therapies got better. Over the decades, with improving systemic therapies, there was a chance that we actually see disease recur. And when it recurs, it may recur in a local pattern of spread. What do I mean by that? Is that we've done a number of studies where we've looked at patients and identified what is the most likely time point and site that the patient's disease returns. It usually returns in original sites of disease, okay? And so if we offer radiation to those original sites of disease, along with the patients receiving systemic therapy, we may be able to reduce increase the timing which patients have a disease-free interval, okay? The other aspect of this whole enterprise that allowed us to consider radiation more than just for palliation is that targeted therapies got better, the introduction of immunotherapy improved patient outcomes, and really imaging. Imaging helped us identify disease at earlier stages in the metastatic dissemination. And imaging also allowed us to use high doses of radiation. And I'm sure you've all heard of SBRT, high doses of radiation given in very few or limited number of treatments to eradicate and kill cancer where we aim those radiation beams. And so those radiation beams are aimed with extremely high precision. And I can literally radiate any metastatic site from the top of your head all the way to the bottom of your feet. And so it was the evolution of this form of radiation, SBRT, the integration of daily imaging to pinpoint our treatments, the integration of imaging, functional imaging, for instance, PET CTs to diagnose metastatic disease at an earlier stage in development, and the evolution of systemic therapies that all played a role in helping us optimize local therapy in the oligometastatic disease state.